My name is Gianluca. I'm an anesthesiologist at the Montreal Children's Hospital. I'm doing a master in experimental surgery with the supervision of Dr. Ponaro. So today, I'm going to present, I'm going to do a lecture about the physiological basis of virtual reality. I'm going to just give you a summary of the use of virtual reality in pediatric anesthesia, and I will focus more on the use of virtual reality in anesthesia education, in particular based on the study I'm actually doing. Hopefully nobody will fall asleep. So I have no disclosure. I guess everybody knows what virtual reality is a simulated 3D environment where the user can explore and interact with that environment and feel that is like is real. For those who like movies, probably the most famous one is The Matrix. More recently on Netflix, there is this series 1899, which is based on virtual reality. So normally I would ask the audience if they know when virtual reality was born. Probably I believe that the oldest idea of a virtual reality world dates back in Plato's age, so fourth century before Christ, with the myth of the cavern. This here is represented. But to be more practical, the first, let's say, equipment that shows a sort of virtual reality environment was invented in 1838. It was the stereoscope. About a century later, there was the first book about virtual reality, the Pygmalion's spectacles, where the main character could wear these goggles and enter in a sort of movie where he could interact with people, feel smells, and basically live in this virtual reality environment. Then the technology improved, the virtual reality became more accessible, and the shift was really in 2010 with when they put Oculus VR on the market, and now it's spread around in many environments. Before talking about where we can use virtual reality, I want to introduce the concept of the body matrix. So our body has a spatial representation of our body in the environment. And this is due because the body has to take the information from inside the body and outside the body, put them together, find a coherence, and create a simulation to react properly. So, for example, if someone touches our hands, we're going to see our hand be touched, and we're going to also feel it, and the body has to recognize that it is actually part of our body that is touched. The body matrix is the base of the virtual reality, and for those who are interested, is based on the same physiology of the rubber hand illusion. Here I'm trying to, to represent. Let's see if it works. No, unfortunately, it doesn't. So, when a patient, when a user is in the virtual reality environment, it doesn't feel only that the virtual reality, the virtual environment is real, but he also believes that his body is a virtual body is real. So let's say how the virtual reality works. So basically, you are in this nice environment with these puppies, and you are absolutely involved in this, and you have no idea what's going on outside. So there are 5 aspects of the virtual reality that are fundamental, pivotal for it to work, which are the engagement and presence, the interactivity, the embodiment, the social interaction, and eventually the customization. So I'm going to present very quickly the implementation of virtual reality in medicine. So in this case, For example, it was implemented, it was studied to see if distraction can decrease pain. And in these cases, in these studies, they measure pain through a functional MRI. And just to give you a brief understanding, so whenever a person has a painful stimulus, there are different areas of the brain that are activated. So if you keep the areas in the brain activated, you see what the virtual reality does by basically inhibiting some of this area, you can understand why patient may feel less pain when they are in a virtual reality environment. Similarly, the virtual reality was implemented in anxiety and autism, then again in anxiety and pain, like when we put an IV. It was very effective in bone dressing, and again in dental procedures, these in kids. And it was also compared to music therapy to see if it could decrease the stress in breast cancer patients. Is there any question about this part before I move on? Okay, so let's talk about virtual reality and education in anesthesia. So why virtual reality may be important in education? Well, anesthesia has been compared to piloting a flight. So we take off in the morning, we cruise, hopefully in the sun with a calm day, sometime in the storms where we have more troubles and we are more stressed. And eventually, most of the time, we land safely. I'm going to take 3 of your minutes to see why aviation is important and why it triggers education in, somehow. Let me see if it starts. So this is a reproduction of what happened in December 1972.
Eastern 401 heavy. Continue approach to 9 left.
Continue approach, Roger.
And this is a flight that was going from New York to Miami.
Eastern Flight 401 is on final approach to Miami International, runway 9 left. The nose landing gear indicator has failed to illuminate, so the crew cannot tell whether the gear is extended and locked.
You want me to test the lights or not?
Yeah, check it.
Which seat back?
Okay, it could be the light. Could you jiggle the light?
It's got to come out a little and then snap in.
For the moment. The 2000. You want me to fly, Doug? What frequency did he want us on? 28.6. I'll talk to him.
All right, approach control Eastern 401. We're right over the airport here and climbing to 2,000 feet. In fact, we've just reached 2,000 feet. We've got to get a green light on our nose gear.
Eastern 401, roger. Turn left heading 360. Maintain 2,000. Vectors to 9 left final.
Left to 360. I think it's above the red one. Yeah, I can't get it from here. I can't make it pull out either.
We got pressure?
Yes, sir. All systems. Put the damn thing on autopilot.
All right. See if you can put that light out. Now you got to push the switch just a little bit further forward. I turn it to the right a little bit. No, I don't think it's going to fit.
Hey, get down there and see if that damn nose wheel's down.
Okay. You got a handkerchief or something so I can get a little better grip on this? Anything I can do with? This damn thing just won't come out, Doug. If I had a pair of pliers, I could cushion it, but I can. Everyone is absorbed by the crisis, so they don't hear the audio alert announcing a change in altitude.
Pliers. The hell with this. Go down and see if that red line is lined up down there. Don't screw around with that 20-cent piece of light equipment.
Eastern 401, I'll go out west just a little further if we can here and see if we can get this light to come on.
All right.
The autopilot has somehow become disengaged. The plane is slowly descending, and nobody is paying any attention to the altimeter. It's always something. We could have made a schedule. We can tell if the damn gear is down by looking down at the indices. An emergency landing with a possible nose gear problem is neither very risky nor all that unusual. It's an option the captain could be preparing for now. Got to be a faulty light. But this damn thing just won't come out. All right, just leave it there.
Eastern 401, how are things coming along out there?
The controller's inquiry is too vague for the crew to realize he's asking about 401's surprisingly low altitude.
80. Hey, we did some of the altitude here. What? We're still at 2,000, right? Hey, what's happening here?
Okay, so this crash causes about over 100 fatalities. Hopefully 79 survived. And from there on, learning in simulation became important, fundamental in aviation, and you can, as you can tell, also in medicine, in particular in anesthesia. So over the years, we started doing simulation in front of a computer. Then eventually we were able to attach equipment to the computer to expand our training in our simulations. And eventually we had the virtual reality, which sounds great, and is probably the most innovative equipment we have so far. So, however, our gold standard is a mannequin-based simulation. I'm not going to go through the entire video; it's too long. But I want to give you an idea of what is about. So, basically, we have a bunch of people around. They are working on a mannequin. They have a high fidelity reproduction of the environment, and they train communications and skills, awareness, and so on and so forth. So what are the limitations of the mannequin-based simulation? Well, first of all, you need a simulation center. The simulation center can't be everywhere. So it must be located in a few places, like Montreal for us, which means that it has a limited access in terms of time and distances. And you need also a lot of people, actors, raters, and so on and so forth. So it costs a lot of money. What is the alternative? Oh, I'm sorry. I should also say that you can't really train too many people on the same skills. You can have different people training different skills altogether, but you can't have the same mannequin for the same task on multiple people. So the alternative, as I was almost saying, is to do it in a virtual reality environment. So you just reproduce the OR, in this case, environment, which is the study I'm doing. And you just need a room big enough to let the trainee walk around, and the trainee, which is here in the right picture, and the proctor that drives out the trainee to go to the scenario. So far, the virtual reality has other advantages, which means that comparing to the high fidelity simulation, appears to be less expensive. So it costs about 1/4 of the high fidelity simulation, taking all the expenses together. However, there are also side effects. The most important one is what is called a VR-induced symptoms and effects, or VISRE, which is basically cyber sickness. There's another synonym that you can find in the literature, which represent discomfort, malaise, including dizziness, fatigue, difficult concentrating, and so on and so forth. It's been reported up to 90%. Probably something around 20-30 is more realistic. There are not many studies on these side effects, indeed. And it may decrease when there is too much sense of presence. I'm going to go there in a second. There are different theories behind the cyber sickness. The most of them, the first three, were theorized in the 70s, and the last one, the postural instability, in the 90s. So briefly, what they are saying, the sensory conflicts basically says that because we get information from different sensory pathways, vision, touching, and so on and so forth, our brain is unable to find a coherence, and then gives the dizziness. The other theory is the evolutionary, which means that it's like when you drive a plane or a car, and you have actually say a car more than a plane, and you have motion sickness, we haven't evolved far enough, I mean, well enough or fast enough to be able to live in a world, in this case, a different speed, or in a virtual world. We need more time to adapt it. The neural mismatch is not much different from the sensory conflicts. It's basically say that we have all this information coming in our brain, but there is no match with all our simulations that are stored in our brain. So the brain can't really understand what's going on. And that's why you feel sick. The last one is the postural instability. Is when you, for example, you go on a high bridge, and you basically have the vestibular discomfort because there is no match with the rest of the information the body gets. That said, there are some risk factors, in particular, older age, visual stimulation, locomotion, exposures more than 10 minutes, gaming content, and 360 videos. I don't know if anybody of you ever tried the virtual reality headset on a gaming. If you use either the teleport or you, instead of moving, you just pretend your avatar to move, this creates a lot of sickness. And the more complex is the environment, the higher is your embodiment and sense of presence. So the higher is the risk of having a sort of mismatch of what is going on and feeling sick. It's also true that with the new headset, which have a much better ergonomics, and they are more they are nicer from under different points of view, the risk of visual or cyber sickness is much lower here. In the last study has not been reported. So there are other limitations that we should be considered, especially for education. One is that you interact with the environment mostly with controllers. You can't really touch things. There are some feature where you can have your hands tracked, but most of the time you need to use a controller to interact with the environment. And the second, which is maybe less important in adults, but still, the headset weighs about 500 grams. If you put an extended battery, you go to about 600-700 grams, which may be tiring for some people. So, in summary, what are the advantages of the virtual reality here in red? First, there is no time or space constraints, so you can do it everywhere. Most importantly, you can theoretically deliver this in a remote location, like up north. You don't have to have people coming to Montreal. Can facilitate social distancing, like in case of COVID. You don't need actors. Actually, you can have other trainees join you with another VR set, but you can do the scenario alone. You still need probably a proctor. It appears to be cheaper than the high fidelity simulation. It can be customized, and you can do multiple repetitions. In other words, when you go into in the simulation center, you lock a certain time, and that's the time you have. With the virtual reality, you can repeat as much as you want. Downsides, well, one is the cyber sickness, as I was mentioning. The other is that so far you can't really teach the technical skills, like intubate for us, for the anesthesiology, like intubating a patient, putting in an IV. There are some scenario out there in North America in particular, where they reproduce the CPR. So there is some technical skills that you can teach and you can learn, but most of them are still inaccessible through a VR environment. It's still roughly costly, especially when you had to develop a scenario from scratch. It's unclear, and is one of the challenges I found in my study, how complicated is the interaction between the proctor and the trainee. And most importantly, as far as I know, there are no studies showing the superiority of not the high fidelity simulation, but the VR over the high fidelity simulation. So, and that is the part of my study. How can we assess, see if VR is better than the mannequin-based high fidelity simulation? Well, first of all, especially this is a paper written in anesthesia, but I believe it applies to most of the fields in education. Whenever you implement a simulation, either VR or something else, you have a sort of realism which needs to be taken into account, and then you should compare your new equipment with the gold standard. In our case, the gold standard is the mannequin-based simulation. So the hypothesis of my study is that there is no difference in VR and mannequin-based simulation in terms of quality of training, which means that the null hypothesis of my study is that the high fidelity simulation is actually superior to the VR. I apologize for the misspell. So what I did, what I designed a observational, well, a comparative, I should say, non-inferiority study, and I'm planning to enroll residents in anesthesia. They will be stratified. The enrollment and the randomization will be done by year in order to have a sort of similar experience with the clinical scenarios and with the simulation. And we're going to have a pre-test phase. In this pre-test phase, we're going to divide the group in two. One, it will be the VR group, and the other will be the high fidelity simulation group. Now, they're going to undergo to the same scenario. The difference will be the way this scenario will be delivered in VR or in a mannequin-based. And then they're going to have the routine debriefing that we do after simulation. Then we're going to let rest for a while, usually 2 weeks washout. In this way, they're going to somehow forget about the simulation, but retain some information. But we don't want to have too much time passed, because we don't want them to be exposed too much to clinical cases that may resemble the post-test phase. The post-test phase is going to have all the participants together, and then they're going to do our gold standard, which is the mannequin-based simulation, and the scenario will be different, and then it will be the end of the study. So what we're going to do, we're going to basically measure the quality, their improvement throughout the 3 different scales, validated scales: the MEPA GRS, the Ottawa GRS, and the ANTS. So the MEPA is the management of crisis in pediatric anesthesia. The Ottawa is the global rate scale in crisis management, and the ANTS is the anesthesia non-technical skills scale. And these are the scales validated. They go from 5 points to 7 points, depending on the scales. You have an overall performance grade, and then you have also subcategories that you can analyze. Now, what is going to happen? So, as I said, one group is going to have the scenario, and you're going to have the VR, and going to do the VR only once. The mannequin-based simulation will be used twice, one for the first scenario and then for the second scenario, where everybody will be together. So just to be summarizing, pre-test phase, everybody does this scenario. They're going to be evaluated with these scales. Then post-test phase, they're going to do this different scenario. They're going to get evaluated again. Then here I'm just reproducing the way we're going to try to optimize time in a way that we can have a debriefers that alternate themselves while the rater evaluates each candidate. And these are the study outcomes. So our primary outcome will be the overall Ottawa GRS. So basically, we're going to look how well they improve from the pre-test phase to the post-test phase. We're going to compare the VR with the mannequin-based simulation. And then we're going to test also the other scales. We're going to also look if there is any difference before actually doing the test to see if the groups are homogeneous or not. And then we can also evaluate these scales by PGI seniority, like juniors versus seniors, let's say the first 3 years versus the 4th and the 5th year. And in order, those outcomes are to evaluate to see if the VR is as effective as the high fidelity simulation. But what about the quality? Do the trainee like the VR? Well, we're going to measure these with a 5-point Likert scale, which is going to be a survey, and we're going to see if they actually like the VR more or less than the mannequin-based simulation. We're going to run some statistics. Given the small number, they're going to talk in a second, there will be more non-parametric, and basically we're going to just compare the post-test scales in the different groups. We can also compare if there is any improvement as we are expecting between the first scenario and the second scenario. We can also compare this improvement along different years, seniorities, and we want to look into the inter-rater reliability, because this has been already published and proved for the scales that we are using. So basically, we don't need 2 raters. We're going to use only 1 rater. Sample size. So this is a non-inferiority study, which means that we want to see if our study group should be, we are expecting the study group to be equal or superior to our gold standard or control group. So how do we define a similar outcome between the groups? Well, there are a few studies that did that, and basically, if you take the Ottawa GRS score, you measure these scales before, during the first scenario, and then after the second scenario, you are expecting to get an improvement of overall performance of about 0.6. So 0.6 will be our threshold to consider the difference educationally significant. So if there is a difference more than 0.6 points between the 2 groups, means that one of the groups, in this case the VR we're expecting, will not be non-inferior. And sorry, based on this sample size, we are expecting to need about 8 trainees per group. So that said, what are the challenges that we faced? So first, graphics. Fabio knows better than me that designing a scenario is extremely complicated, requires a lot of work. So we've been working a lot to improve our graphics, and I believe we are now at a very good point. The other problem is the proctor interface, which means that you want to see what the trainee does, but you also want to see the monitors, and we are trying to collect everything, put everything on the proctor's laptop. When you go to a simulation center, you have one person who works on the vital signs, the other looks at the trainee, another one can give a direction. We want in the 4th one or 3rd one raise the trainee. We are trying to compress everything in once, so this can be delivered in places where you don't have a lot of people that can help training the resident, for example. So the proctor is supposed to trigger the launch the dialogues put them the medication that the trainee wants to give, changes the vital signs, even though there are some preset vital signs, which means that if the trainee does what is expected to do, he's going to just fly, and the proctor has only to click on the proper phase of the scenario. If there is something outside the normal is when the proctor has to play around. So we try to optimize and simplify this interface as much as possible.
You're finally here.
And this is basically what is happening
Healthy girl
now.
having a posterior
So
spinal fusion.
I'm not sure you can actually hear, but basically what is happening is that you can see on the left the proctor view. So the proctor is actually looking at what the trainee is doing. And on the right, you have actually the trainee headset recording. So the proctor can really see what the trainee sees to understand if he actually is distracted by something that is not pertinent to the scenario. But you can also change the view and just look at the monitor, for example, to change your vital signs. And you're going to have some dialogue throughout the case, so the trainee can somehow interact and have a closed loop of communication with the avatars. So study timeline. So I believe we have finished to do the 95% of the scenario. Scenario is almost ready. We're gonna test it again for these in February and in March. We're gonna start the resident enrollment in April, and hopefully we're gonna do the study in May. We believe in May 3rd and May 17th, and then analyze the data. I'm going to just quote one who was the pioneer of virtual reality and virtual reality in medical education, who said, is Marion Kruger, who said that VR arises at the moment when computer technology in general is moving from automating the paradigms of the past to creating new ones for the future. Okay, my lecture is finished. I'm open to questions. I went a little